Thanks. I'm really happy to be here. So Marc Lafrance has raised some really important questions about the relationship between the kinds of media representations we see and our sense of self, and also our collective conscience. And I'll be also raising those kinds of questions. I'll also be asking us to think specifically around issues with regards to HIV education in terms of what we see, but also what we don't see, and how absences and invisibilities also tell us something very important about the ways we understand sexuality and identity. To begin with a general context around HIV/AIDS, HIV stands for human immunodeficiency virus. It leads to a syndrome, as you may know, called AIDS, acquired immune deficiency syndrome. It's one of the most important public health crises of our current time. I'll talk for about 15 minutes this evening, and in that time, globally, there will be 60 deaths related to AIDS and 69 new HIV infections. So if the impact of this epidemic cannot be denied, what do we do about it? How do we respond? Thinking about HIV prevention is one way to think about developing a response. And so I want to talk in particular about a research project I've been involved in called Polyvalence. And it's a project that focuses specifically on individuals who have sexual relations with both women and men. And there are some interesting reasons to think about focusing on this particular population and this particular reality. Firstly, in looking at HIV/AIDS research and policy, there are increasing rates, particularly amongst heterosexual women. And when one examines the policy frameworks related to it, the policy frameworks say that one of the reasons heterosexual women are at increased risk for being infected with HIV is because of their involvement with men who have bisexual behavior. So bisexual men are invoked in HIV/AIDS discussions in a particular kind of way. As for bisexual women, when one looks at the epidemiological data, the scientific data, with regards to the prevalence of HIV, but also other sexually transmitted diseases, one finds that bisexual women have higher rates of HIV and other sexually transmitted diseases, notably herpes and chlamydia, compared both to lesbians or to heterosexual women. So there are some good reasons to think about focusing on these particular realities. Even though these realities are quite present and quite visible when one thinks about these issues, one is actually hard-pressed to find an education pamphlet that addresses these realities. If you go to CATI, the Canadian AIDS Treatment Information Exchange, it's a national organization located in Toronto, which has a mandate that includes treatment information with regards to people who are HIV positive and also prevention. And they have a database around the kinds of prevention materials that have been created with regards to HIV/AIDS in the Canadian context. If you do a search on that database to try and find something specific to bisexual men and women, you can't find anything. So this raises the broader question, who makes decisions about the kinds of HIV education that we see? How do those decisions get made? What populations count? And what ones might be ignored? To ask those questions automatically forces us to think a little bit about the realm of social policy. And I've put a slide here up from Leading Together. It's a strategic planning document put together by the Public Health Agency of Canada. And thinking about strategic planning documents can help us better understand how the actual institutions work that then support what kinds of HIV education gets done on the ground. And so if you read Leading Together as a document, it basically says, you know, what we do is we create HIV/AIDS policy based on the cutting-edge research that's available, and also based on our consultation with key stakeholders. What they mean by that is our talks with people who work in the field, community-based AIDS organizations being central among those, right? The Leading Together document outlines a number of particular populations that are then identified as priorities for HIV/AIDS education in Canada. These include gay men, intravenous drug users, Aboriginal people, women, prisoners, and people from countries where HIV is endemic. What that means is where HIV is quite prevalent, a minimum of 16.5% of a national population. So there's an absence of thinking about bisexuality within the political priorities identified within Canadian HIV/AIDS policy at the Public Health Agency of Canada. And if that policy appeals to research, one of the things we need to do is to think a little bit about how do we do research in regards to bisexual men and bisexual women? What kinds of research frameworks are available? And so I'll tell you one story or one kind of main research project, a national survey done on men who have sex with men, so including gay men, bisexual men, and men who have sexual relations with men but who may not call themselves gay or bisexual, asking them about their attitudes and their information and their behavior with regards to HIV/AIDS. And in this study, they asked people, how do you define your sexual orientation? Do you call yourself gay? Do you call yourself bisexual? Do you not use any label? And they also asked the respondents to say, tell us about with whom you have had sexual relations in the past year. And here's something that's really interesting. The research team coded the data in order to make sense of it. And in order to be considered a bisexual man in the context of this research, the male respondents had to both self-identify as bisexual, and they had to have sexual relations with both men and women within the previous 12 months. If they'd had only sexual relations with men in the previous 12 months, the researchers recategorized them as gay men with a previous heterosexual experience. Gay men with a previous heterosexual experience. So, in my view, this kind of recoding of the data tells us a lot about particular cultural views of sexualities. Which kinds of sexualities are seen to be credible? Which ones require proof? Which kinds of sexualities just exist en soi, as is? Which ones need a little bit more evidence attached to them? Which kinds of sexualities exist forever? And which ones come with an expiry date? To return to HIV/AIDS education, if there's an absence of educational materials specific to bisexual men and women, and if policy is based on existing research, one of the things we need to understand is that there is no education because the existing research actually makes some bisexual men and women disappear, right? So if research can be part of the problem, what's the solution? So Polyvalence is a community-based research project. I'm not alone in it. There's a community advisory committee of people who work with me on this project. They have expertise in questions of sexuality and public health in particular. Quite simply, we decided to interview people and ask them, what do you need? What do you want when it comes to HIV/AIDS education? What do you think about the education that's available and that's out there? Do you like it? Why? Why not? Is it adapted to your needs? And specifically, what are your information needs? So this is an interesting shift of focus. Most of the social science research that's done in HIV/AIDS asks people to talk about their behaviors. We didn't ask people to talk about their sexual behavior at all. We said, what do you want? What kinds of posters, pamphlets, ads should we create? There's an action component to this research, so we wanted not just to document what might be the problems or what do people want to do, but we wanted to work as a community advisory committee to create some relevant educational materials based on what people told us. And so I'll be showing you some of those in just a moment. There are some major research findings. I'll draw your attention to a number of issues. First and foremost, the need to include information relevant to women. And this was one of the most astounding results of our research. So people said, you know, every time I look at HIV/AIDS education, they only talk about men's bodies. One woman we interviewed said, I went to an AIDS organization, a very well-known and very well-respected AIDS organization. I told them I have sex with men and women. I want relevant information about STD and HIV transmission for me and my partners. What can you give me? And she was handed a pamphlet directed to gay men with the caveat, well, we don't have anything explicitly for women, but it's sort of basically the same. So here you go, right? In 2006 in Montreal. The other issue I will draw your attention to is the need to avoid a technical, specialized vocabulary. And I can talk more about this in the question and answer if people are interested. This is really interesting because those of us who work in public health and who work in the field, you know, we have a shorthand, right? We talk about STIs, sexually transmitted infections. The people we interviewed had no idea what we meant by the term STI, right? And they said, you know, you should use the term STD. We know what that means, right? Similarly, working in HIV/AIDS, we use the term seropositive all the time, but the people we talked to had no idea what that meant. I want to draw one quote, and it's a quote from a man who's involved in swinger communities. So swingers are couples generally considered to be heterosexual who exchange sexual partners. I'll read the quote and then I'll talk a little bit about why I think it's important. Well, I wouldn't necessarily think about it. Sure, I'm thinking about it for 2 minutes. Of course, it's true. But I never thought about having to change a condom, you know, before you change partners. That too, you know? What happens with, I don't know, an evening of 6 people? You're not going to think about you need at least 6 condoms per man. This isn't something that I thought about from the get-go. It's totally logical. It's just that since all of the information available is based on exchanges between 2 people, it's not the kind of detail that I'd heard about before. So I think this is a significant quote for a couple of reasons. One, it tells us what happens when there's an absence of information. People don't actually know what to do. People don't know how to protect themselves and their partners. And secondly, this particular interviewee went on to say, you know, I didn't understand this when I first entered into a context of swingers and group sex, right? And how could I understand it? Nobody told me. It was my girlfriends and the women with whom I was involved who explained it to me. They explained to me, baby, if you don't change a condom, you might be safe from HIV and STDs, but I'm not. If you've just been with Julie and then you come to me and you haven't changed a condom, if Julie has chlamydia, I could be exposed to it. So this also tells us then about the invisible labor that women do in HIV and STD education when public health fails, when public health doesn't consider basic realities such as group sex and swinging, right? It's women that pick up the slack. So we did a bunch of interviews and asked people what they want. I showed some of the main results earlier. And then we developed some posters and educational materials. We had a small-scale campaign in February 2008 with these posters. And I'll draw your attention to a couple of different elements. One, we didn't want to have a didactic approach, a kind of like wear a condom, protect yourself. People told us, you know, we're really tired of these kind of generalized messages, right? They don't really say anything. What we wanted to do was to get people thinking, right? We wanted to ask them questions. We wanted to say, you know, do you know what the issues are in relation to the transmission of herpes between women, for instance? The answer's on our website, just so you know. This is our swinger ad. We kind of really like this one especially. And there are postcards out at in the lobby, so you can take postcards and send them to your friends at the end of the evening if you like. So, pardon. This is our website. If you have specific questions around HIV, STD transmission between men, between women, between men and women, you can find the answers there, as well as link to relevant health services. I want to conclude with 3 main things with regards to research. So one, sometimes research can be part of the problem, right? The recoding of data, which makes people literally disappear, can be part of what we need to unpack, right? That research can actually hinder our understandings of sexuality. If research can be part of the problem, the second point I want to conclude with is research can also be part of the solution. And in particular, there's an urgent need for critical social science research, which helps us understand what are the blind spots in our response to date, right? A need for critical research which does not just take the categories and the populations identified to us by public health as the only ones upon which we should work, right? But which goes a little further, which pushes a little bit more. And finally, there's a need, I think, for research, not only which describes these are the problems, these are the ways people can't access information and services, but a need for research that connects knowledge to action. And I think if we have any hope in developing innovative responses to HIV/AIDS, particularly at the level of prevention, it's in forging that kind of connection between knowledge and action. So thank you very much.